My name is Benoit ARVEILER. I'm a molecular geneticist at the University Hospital of Bordeaux in France. My team and myself have been working on albinism for about 20 years now, and I would like to thank the organizer for their kind invitation to give a lecture on the genetics of albinism. This is truly a big honor for me. Albinism is a genetic disease affecting 1 in 17,000 persons worldwide. It's a monogenic and recessive disease. It's genetically heterogeneous with 20 genes identified so far, plus 1 gene for a closely related condition, FONDA. Albinism is also phenotypically heterogeneous. Symptoms can be more or less severe. That's the case for hypopigmentation, for instance, and for visual acuity. Some patients have both cutaneous and ocular symptoms. Some have only ocular symptoms, and some have a syndromic form of the disease. So 3 main classes of albinism. I'm going to go through the 3 of them now in a row. To start with oculocutaneous albinism with 8 subtypes, characterized at the clinical level by a variable hypopigmentation of the skin, of the hair, and of the iris, with more or less tendency to tan in the patients. Central to the disease are the ocular features characterized by nystagmus, foveal hypoplasia, misrouting of the optic nerve, iris transillumination, retinal hypopigmentation, and reduced visual acuity. In the ocular form of the disease, with 1 gene OA1, which is X-linked, and the related FONDA, there are, of course, only ocular features, which are the same as those described before. And just I want to add here that in the FONDA, there is no iris transillumination. Syndromic forms, Hermansky-Pudlak syndrome with 11 subtypes and Chidiac-Higashi syndrome with 1 subtype, are characterized by oculocutaneous albinism plus a number of symptoms that affect different organs. In Hermansky-Pudlak syndrome, we'll have bleeding diathesis, reduced number or absence of dense granules in the platelets, and in the most severe forms, we'll have lung fibrosis and granulomatous colitis. The severity of all the symptoms is variable throughout the various syndromic forms of these HPAs. In Chidiac-Higashi syndrome, we'll find susceptibility to infections, neurodegeneration with tremor, abnormal gait, seizure, and progressive intellectual decline. CHS and HPS are both life-threatening, and they require a specific care. As I said, there are 20 genes that account for the various forms of albinism. There are 7 genes identified in oculocutaneous albinism, and we identified last year the gene for OCA8, which is called DCT or TRPE2. For OCA5, the locus has been mapped to chromosome 4, but no gene has been identified so far. In ocular albinism, the gene involved is GPR143, which is X-linked. In syndromic forms, Hermansky-Pudlak syndrome, 11 genes, and were identified and published last year. Block 1 is 5, which is involved in HPS 11. Chidiac-Higashi syndrome, 1 gene called LIST, and the related FONDA, which stands for foveal hypoplasia, optic nerve decussation defects, anterior segment dysgenesis. The gene involved is SLC38A8. Over the years, we have assembled a cohort of just under 1,700 patients, which are all analyzed by next-generation sequencing and array comparative genomic hybridization to look for both single nucleotide variants and for deletions, for instance, in all the 21 genes. You can see here the results of the analysis of all the patients with the number of patients per gene and the percentages as well. And you can see here that OCA1 with tyrosinase accounts for about 40% of patients, OCA2 30%, and the other OCA genes are much less frequent, except for OCA4, which stands for between 9 and 10%. OA1, GPR143, accounts for a bit less than 7% of the patients. Fonda is very rare, 0.5% of the patient. And here you have all the syndromic forms of the disease with CHS and HPS 1 to 11. And you can see that these are all very rare diseases. Although altogether they account for, all the syndromic forms account for just under 7% of the patients. So you can see here that we have had a successful diagnosis in just over 71% of the patients, which was pretty good. And that means that in about 30% of the patients, we do not have the diagnosis, either because there is only a single heterozygous variant in the patients or no variant at all identified in 21 genes analyzed. Intragenic rearrangements must be looked for, since you can see here that they account for more than 10% of alleles. And there is some differential diagnosis in the patients between 1 and 2%. As you can see, we have analyzed more genes, like these 3 genes or group of genes here, which account for, as I said, between 1 and 2% of the patients. So when one gets back to the phenotype of the patients, you can see that there is a whole range of pigmentation defects in these patients, with some patients with no pigmentation at all and others who have normal pigmentation. And indeed, when a patient comes in a consultation, it is impossible to tell in advance what form of the disease he will have and will be found through molecular analysis. And as you can see here on this slide, the 3 circles for the 3 main groups, main classes of albinism do overlap a lot, and this is shown here in red. And this is because there is a strong phenotypic overlap between the different forms of albinism. And indeed, some patients may, for instance, clinically seem to have an ocular form because they have normal or almost normal pigmentation. But in fact, once genetic analysis has been performed, some of these patients may have variants in one of the OCA genes or even in one of the genes involved in the syndromic forms. And this may be, for instance, the case in young patients in whom bleeding or gastrointestinal or lung problems have not developed yet. Quantifying the level of overlap is difficult, but the message here is that classification based on clinical symptoms is not valid and genetic testing is warranted. So genetic testing is necessary, first of all, to establish the diagnosis at the molecular level, and that's mainly because there is no phenotype-genotype correlation, as I already said. Phenotype indeed depends on the gene involved and on the type of variants which are found in the patient. Essentially, and indeed there may be mild and severe variants in all of these genes, and depending on whether the variant is mild or severe, then there will be some of function which will be retained or not for the gene. Well known is this hypomorphic variant of tyrosinase in OCA1, which is called R402Q, which is associated with mild OCA1 when it is in the compound heterozygous status with a strong allele of tyrosinase, and this leads to micronystagmus and low-grade foveal hypoplasia, for instance. Genetic testing is overall and mainly important to distinguish between non-syndromic and syndromic forms of the disease, especially since these syndromic forms will require specific caretaking. Some clinical ocular forms are found in the patients and may be in fact turn out to be due to mutations in the OCA genes or in some of the syndromic genes, especially in the mild forms of HPS 3, 5, 6 or 8 namely. And of course, genetic testing is important for genetic counseling in terms of familial recurrence risk and for allowing prenatal diagnosis in some families. So in conclusion, as I take home messages, I would like to point to four aspects. The first one is that albinism corresponds to a phenotypic continuum, as I think I have clearly shown during my talk here. An extensive phenotypic overlap between the different forms is noticed, and there is hence a need to test all 21 genes to establish the diagnosis. Albinism is an underdiagnosed condition, and this is mainly due to incomplete or atypical phenotype found in some patients with some features missing or being atypical with low-grade foveal hypoplasia, for instance, or micronystagmus or mild hemorrhagic signs in some of the patients with HPS, for instance. Ocular features are central to albinism, and hence they must be investigated with appropriate tools like optical coherence tomography and visual evoked potential, slit lamp as well, and this is very important, and in moderate and atypical signs must when they are found, they must suggest a diagnosis of albinism. And of course, appropriate hematologic tests must be performed as soon as a syndromic form is suspected. I would like to finish with by acknowledging my collaborators in Bordeaux, in my team genetics, but also in dermatology and hematology and ophthalmology in the Bordeaux hospital. And also my collaborators in other places in France and abroad, who mainly and very importantly helped us characterizing at the functional level the two new genes for OCA8 and HPS11, which we published last year. And to finish with, I want to warmly thank Jeune Espoir, the French Albinism Association with whom we collaborate for so many years on both the diagnosis and research aspects of albinism. I thank you very much for your attention.